Yes, Dr. Rupak.
A very good morning to you all. I would like to thank AOS for giving me this opportunity to speak to you about a series of challenging cases in cataract surgery. I would like to present the first case. The case one is a 60-year-old female person with NS2 cataract, planned for phacoemulsification with IOL, implantation of a 22.5 diopter VVT IOL. So case went uneventfully, very slow injection of the VVT IOL. It was a straight shooter and then bang. So the shooter messed up and it released fast, and the lens was released into the bag. As you know, there's a small PCR. Pointer, please. Pointer. There's a small PCR, and the leading haptic had opened into the vitreous cavity. I was quick enough to rotate the IOL and bring it back into the bag. And the trailing haptic I have tucked into the bag and slowly rotated the IOL and kept everything in position. So after this maneuver, I found out that there is no vitreous in the anterior chamber. And then I went ahead with the irrigation aspiration and slowly completed the irrigation aspiration. You can still note the small PCR being there, but there's no vitreous disturbance. So I closed the incision and completed my surgery. So the take-home message for this video is use of a screw type of injector would have prevented this kind of mishap. And don't panic in this kind of situations. Try to react very quickly, position the IOL in the bag, and I had a post-op result of 6.9 for this case. Case number 2, it is a white intermittent cataract. I injected viscoelastic and later followed by a high molecular weight viscoelastic. Then proceeded with opening the capsular bag slowly, and then we had one Argentinian flag sign. So I did not panic. Initially I had panicked, and now I did not panic at this time. I used micro-rexus scissors to cut open, give a nick, and try to complete the rexus from the other side, and then I had the second Argentinian flag sign. So I went ahead with the other side, gave a nick from the other side and tried to complete the rexus from the other side, and slowly I went ahead, but the rexus would not listen to me, and I had the third Argentinian flag sign. Now I went ahead and completed the rexus slowly but carefully. I found out that it was not enough, so I went ahead slowly, tried to open and tried to increase, but the rexus would not listen to me. Now I go ahead and then reduce my phacoemulsification parameters. I was in very low bottle height, about 20 bottle height, 20 IOP, that would be around 27 bottle height. I was going very slow with phacoemulsification, not trying to separate the lenticular or nuclear fragments much, very small, minute separations, then very slow phacoemulsification. I was trying to do it, but it was a very leathery cataract, and very slowly I completed one quadrant. And then went ahead with the other quadrants. All this while I was very careful not to let over my foot pedal from the phacoemulsification foot pedal so that I would not collapse the chamber. And in fact, I had not removed the phacoemulsification probe from the eye for a while. So this is in four times the speed. I went ahead and removed the last instrument. Then before I removed the instrument, I put in viscoelastic and kept the chamber maintained at all times. So I went ahead and implanted a single piece IOL, and the case went fine. So the take-home message is usage of low phacoemulsification parameters and high molecular weight viscoelastics can save you from these kinds of situations. Case 3 is a 14-year-old male who had a trauma, had a corneal tear repair before, and presented to me with this kind of picture. So I went ahead with the surgery, planned a surgery. It was very small areas to enter, and they had a lot of scarring. It's a white intermittent cataract. I planned a very small rexus. To start with, I used a micro-rexus forceps to start with and try to make a very small rexus with a plan to increase the size of the rexus at a later stage. I could complete the rexus. As this was a young male, I took the incision in the temporal. I sit on the temporal side. Superior, it is not possible to take an incision. I used only irrigation aspiration because it was a young patient. I was in very low bottle height and with very low phacoemulsification parameters, which I will discuss on the next page. And I used irrigation aspiration to complete everything and noticed a small anterior capsular rent. So luckily, this anterior capsular rent did not extend, the trauma did not extend posteriorly. There was no PCR. So went ahead and injected the single piece IOL. So you notice that by the maneuvering of while inserting the lens, the main incision opened up and extended up to the area of the previous trauma. So and then now I try to increase the size of the rexus. I give a small nick and try to open it up. So as you know that the main incision has extended towards the place where there was a previous trauma. This was a two-month-old trauma. We had removed the sutures and then planned for the cataract, but still because of the pressure inserted during the lens implantation, the wound opened up, and then now I had to do a suturing and close the wound. As you can see, there is no leakage of the wound, so I had to close the wound. So the take-home message from case 3 is positioning of the main incision. I could have positioned the incision little inferiorly so that this could have prevented this mishap. I was on low parameters, so chamber maintenance is of very importance. As you can see, I was always on 20 IOP, that translates to 27 bottle height, and low vacuum about 100, and aspiration flow rate about 14. I could comfortably complete this case. So this is the post-op day 1 picture of this case. Coming to the case 4, it was a 60-year-old male patient with grade 4 cataract and a 7 millimeter pupil. As you can see, this case was posted for phacoemulsification with femtosecond laser assistance. After I docked the case and completed my capsulotomy, the patient moved and we had a suction loss. So only 1 second of lens fragmentation happened and the machine aborted the case. At this stage, because it is a grade 4 cataract, I still wanted femtofragmentation, but the machine said that it was not possible. So I had to do a little maneuverability and I had to trick the machine. So we entered the parameter once again on a different patient ID, and that went ahead. So the plan was to do, the blue line indicates one phacoemulsification femtorexis. The red line indicates the another rexis which is planned again on the same patient, but which is a smaller size. Ideally, a bigger size rexis should have been correct, but the pupil size is very small, about 7 millimeters. So I had to plan a rexis on a rexis, and then the machine would give me pass for a nuclear fragmentation.
A minute more.
Yes. So I went ahead in this way, and I could complete. The machine did not give any issues with that, and completed the fragmentation. Fragmentation took 35 seconds. So this is the case. As you can see, there is fragmentation has been completed. I dyed it for better visibility. There are 2 rexises. I try to remove the outer rexis, and then that completes a small ring-shaped rexis part. I slowly go ahead and try to remove the entire rexis. So the rexis comes out. I open it up to demonstrate. There is a small ring-shaped outer rexis, which is around 6 millimeters, and there is a central small rexis, which is around 4.5 millimeters. So I went ahead with phacoemulsification. As you see, it's a dense cataract, and the femtofragmentation had happened, so that caused more softening of the nucleus, and I could get ahead with using very less phacoemulsification energy. You can see it is a grade 4 cataract, and it is a dense cataract. And I could emulsify the entire nucleus. So the take-home message is double capsulotomies are possible with the femtosecond laser, and this is useful in suction losses. Thank you.
Very nice. Dr. Rupak, just a question. I think it's an add-on. I would say the second case where you had 3 Argentinian flag signs.
Yes.
Did you use the high molecular weight viscosity?
Yes.
Yeah.
You always use.
One more thing, unless you deepen the chamber, you're going to have again and again the Argentinian flag sign.
Yes.
It is another go-home message for the beginners who are here around.
Yes.
Now we have the next. Thanks a lot.